Good afternoon, all. On behalf of Unit 1, Department of Surgical Disciplines, Surgery Block, I welcome you all to our CCR. So, now we are going to present a case which exemplifies how one can have problems later on if there is a delay in diagnosis. In our case, the delay was 20 years. And during that period, almost half of the abdominal viscera chose a new abode, that's the thorax, and which was not at all a conducive place for the normal growth of these organs. And the same applies for the growth of the lung, the right lung. And moreover, this problem was associated with potential complications like strangulation, respiratory distress. So, how this case was managed, and to take you through the journey of this patient at AIIMS, I would like to call first Dr. Varnik Goyal, Junior Resident, Department of Surgical Disciplines, Unit 1.
Good afternoon, everyone. I will be discussing the clinical history and examination of a 26-year-old female patient who is a resident of Uttam Nagar, Delhi, and is currently pursuing her post-graduation. She presented to us with the chief complaints of difficulty in breathing and abdominal pain for the last 1 year. Patient was apparently well 1 year back when she developed dyspnea, which was more on exertion. It has gradually progressed from NYHA grade 2 to 3 over the last 1 year. The dyspnea was associated with dull aching abdominal pain, which was more in the epigastric region. It was intermittent in nature, mild to moderate in intensity, and was non-radiating. Patient gives an alleged history of blunt abdominal trauma at the age of 5 years, which was managed conservatively. There was no history of any other non-comorbidities or any prior surgical intervention. The personal history of the patient was non-contributory. General physical examination was essentially normal. On respiratory examination, there was reduced chest movement with decreased chest expansion over the right hemithorax. Dullness was present over the right lower lung fields. Also, there was decreased breath sounds heard over the right hemithorax. The rest of the systemic examination was within normal limits. So, to summarize, a female in her mid-20s with gradually progressive exertional dyspnea, which was associated with dull aching abdominal pain, having a history of blunt abdominal trauma in childhood, which on examination revealed reduced breath sounds and dullness on percussion in the right hemithorax. Considering any lung pathology, patient was further evaluated. Her routine blood investigations were within normal limits. A pulmonary function test was done, which was consistent with the findings of a restrictive lung disease. Now, I would like to invite Dr. Sudeep from radiology to discuss the radiological findings of the patient.
So here we have the frontal radiograph of the patient. Coming to the region of interest, we can see on the left side, this is the hemidiaphragm, which appears to be smooth and maintained dome shaped of the diaphragm. But on the right side, we can see the hemidiaphragm is not at all perceptible. Also, there is elevation of the diaphragm with some herniation of bowel loops. Apart from that, there is no significant tracheomediastinal shift. The rest of the lung appears to be normal. There is no bony cage abnormality. So here we have CCT chest and abdomen soft tissue window in sagittal, coronal as well as axial section. So this is the left side where you can see this is the hemidiaphragm, which appears to be smooth and continuous. But on the left side, you can see there is a large defect, which is extending from the anterior to the posterior end of the thorax. And this is the area where you can see the torn segment of the diaphragm, which appears to be smooth and thickened, which usually happens in chronic diaphragmatic rupture. Also, you can coronal section also, you can appreciate that diaphragm. In the coronal section, in the fourth image, you can see this is the left crest of the diaphragm, but on the right side, the crest of the diaphragm is not at all appreciable. So coming to the herniated contents, we can see this is the right lobe of the liver, because on the lateral side we can also see the gallbladder, which is also herniated into the thoracic cavity. This is the body of the stomach in the pylorus, which is also herniating into the thoracic cavity. This is the duodenum, and these are the large bowel lobes. This is the cecum with the IC junction here, and this is the ascending colon, and this is the transverse colon. These are the mesentery and the mesocolon. However, the enhancement pattern of the wall of all the bowel loops appears to be normal. There is no air fluid level within the bowel loop. There is no significant dilatation of the bowel loop. Coming to the status of the lung in the CT pulmonary window, axial, sagittal, and coronal section, we can see in the right lower lobe, the posterior basal segment appears to be collapsed. There is a segmental collapse of the right lower lobe. Apart from that, rest of the lung appears to be well aerated. There is no significant abnormality. There is no pleural effusion. Summarizing my finding, there was a large chronic diaphragmatic hernia with herniated bowel loops with no significant complication. Thank you. I'd like to invite Dr. Anshul for further.
Good afternoon, everyone. I would like to summarize the key anesthetic challenges we experienced while managing this case. As my colleague has already highlighted the history points, one point which I would like to highlight here from anesthetic point of view, anesthetic considerations point of view, is that this patient experienced trauma at the age of 5 years. Lung, usually alveolar proliferation, it continues up to the age of 8 years. Although further functionality and improvement in lung function, it is up to adulthood also. So that's why probably the pulmonary involvement was not that severe. It was associated with moderate pulmonary hypoplasia only. Right side lung was moderately hyperplastic, and the patient's preoperatively breath holding time was well more than 25 seconds, which is indicative of a good cardiopulmonary reserve. But although in last few months the patient's NYHA grading it deteriorated, and that's why patient presented to us with complaints of breathlessness and respiratory distress. So since the contents, the abdominal contents in the thorax included stomach, the liver, the gallbladder, as well as the bowel loops, there was a significant risk of aspiration in this case. Therefore, our plan was rapid sequence induction of anesthesia, in which we completely avoid positive pressure ventilation, and following which we inserted a left-sided double lumen tube to ensure lung isolation. That was the demand of the surgery. Initially, the surgeon began with VATS, and later on they had to convert it into open surgery because of the big size of the diaphragm defect. Our plan for analgesia was a multimodal analgesia comprising of thoracic epidural, which was inserted pre-induction, and that continued up to 5 days post-operative period. So intraoperatively, we instituted one lung ventilation. A restricted tidal volume up to 6 ml per kg of idle body weight was administered to avoid the risk of barotrauma. As these patients, they have poor pulmonary compliance, they carry a high risk of barotrauma and resultant pneumothorax. So we have to limit the airway pressures at all costs. Therefore, intraoperatively, we try to restrict our tidal volumes. For that, we also had to permit some degree of hypercapnia. The end-tidal carbon dioxide concentration was allowed to go up to 45 to 48, 50 millimeter over mercury. Initially, under laparoscopy, the surgeons tried to perform VATS, but as I already told, when the incision was converted into a large thoracoabdominal incision, then ensuring adequate analgesia became more challenging for us. We took the help of repeated epidural boluses through local anesthetic along with opioids and IV analgesics comprising of paracetamol and ketorolac. So eventually there was a creation of neo diaphragm, that is the right crus of the diaphragm was artificially created. So the key anesthetic challenges, as I've already highlighted, they were we were ventilating a hypoplastic lung, so we had to limit the airway pressures. There was a significant risk of barotrauma in this case. After the viscera was reduced, there was a transient intraoperative hypotension that was managed by boluses of injection ephedrine. The patient did not go on any vasopressor support or infusion till the postoperative period. The patient fared well. Then later on, during extubation, it was like a by-edged sword here. We could have, because the abdominal contents were large, they were reduced back into the abdomen. The intra-abdominal pressure suddenly, had risen. We at one point of time contemplated extubating the patient on table or not, but keeping the patient intubated and mechanically ventilating the patient would have led to a risk of higher intrathoracic pressure. And because a new diaphragm was created, that's why we thought otherwise and planned extubation on the table. We could extubate the patient on table, although a very smooth extubation was planned. We took all the precautions to avoid any cuffing or bucking, which would have actually displaced the diaphragmatic mesh that was the neodiaphragm that was created. Now, post-operatively, the patient retained carbon dioxide for a few hours. The patient became drowsy. A repeated ABG was done. The PaCO2 actually rose up to 50 to 55 millimeter mercury. But this was managed completely conservatively. We gave the patient oxygen supplementation. There was no invasive mechanical ventilation required. So this patient was managed in our ICU for the next 2 to 3 days. Adequate analgesia was ensured. This was very important because we had to begin deep breathing exercises and chest physiotherapy in this patient. Such cases, they have a very high risk of post-operative pulmonary complications. So it's very important for us to begin chest physiotherapy and later on prehabilitation after surgery very soon. So deep breathing exercises were begun within 24 hours of surgery, and the patient fared well. The epidural catheter was kept in situ for the next 5 days, and through which epidural morphine was given twice a day. The patient was very comfortable, was pain-free, and later was discharged. Thank you.
Now I'm Dr. Agam Goyal, Senior Resident, Department of Surgery. We'll talk about the management. So we planned a hybrid procedure for this patient, with including the minimal access approach and the open intralateral thoracotomy. Under general anesthesia, Foley's catheterization was done and ND2 was placed. The patient was put in a left lateral position with a table break of approximately 15%, and adequate padding of the bony prominences at joints were done. These are the port positions. First, a 12 mm camera port was placed in the infraumbilical region on the right side. Under vision, 2 5 mm ports were placed in the left and right paratus region. One 5 mm epigastric port and one 12 mm utility port was placed in the right fifth intercostal space, followed by an anterolateral thoracotomy for fixing the mesh in the hernia defect with the thin rim of the diaphragm. There were certain challenges regarding this case. So it was a rare case. The anesthesia-related challenges, as ma'am already talked about, and the approach was thoraco-abdominal approach. There was significant adhesions of the right lobe of the liver with the right lower lobe of the lung. There was a normal dumbbell-shaped liver with left lobe hypertrophy and the right lobe of the liver in the thoracic cavity, which was typical for us. And the main thing was the thin rim of the diaphragm with the large hernial defect, which needed a creation of neodiaphragm using transfacial sutures as pillars. And finally, the risk of abdominal compartment syndrome due to the reduction of hernia contents in the stomach. Proceeding with the operative video, this is the large hernia defect we can see. The stomach, along with the greater momentum, has herniated into the right thoracic cavity, along with the ascending colon and the transverse colon, which are also herniated in the thoracic cavity. Still, we are not able to see the right lobe of the liver. After complete reduction of the bowel contents, finally, we can see the right lobe of the liver along with the gallbladder into the right thoracic cavity. And when we are trying to reduce the liver, we see that it is connected with the left lobe, which is in the abdomen, by a thin bridge of tissue. But still the right lobe of the liver is not being, we are not able to reduce the right lobe of the liver into the abdomen. So we placed the utility port and the epigastric port for some adhesions, which we anticipated with the right lower lobe of the lung. The adhesions were resected using harmonic scalpel, using traction and counter traction from both the ports. Finally, after the dissection, we can see the collapsed right lobe of the lung. This is the collapsed right lobe of the lung. But still, there were some adhesions of the right lobe of the liver with the major vessels like aorta and IVC. Due to the thin rim of the diaphragm, which was approximately 1.5 centimeter. We made an anterolateral thoracotomy incision to fix the mesh with the thin rim of the diaphragm circumferentially, and we had also to make transfacial sutures to make pillars in the anterior side of the chest wall. The mesh was placed circumferentially, and this is the final view. The inset shows the initial diaphragmatic defect. The oxidized part of the mesh was placed on the thoracic side, and the proline part was placed on the thoracic side, and oxidized part was on the abdomen side. We asked our anesthesia team to expand the right lung, and we placed the right ICD. Post-operatively, serial X-rays were taken to rule out any immediate recurrence or pneumothorax. The patient was monitored for urine output, intra-abdominal pressure monitoring, abdominal gut charting, in view of risk of abdominal compartment syndrome due to the reduction of hernia content into the abdomen, which may lead to compression of IVC, leading to shock and possibility of renal failure. The patient was discharged after fluoroscopic evidence of intact neodiaphragm. Now I would like to call Dr. Parul to give us a review on literature.
Good afternoon, everyone. I would now like to take you through the review of literature for this very interesting case that we have today. So, giant diaphragmatic hernia is a large diaphragmatic defect, approximately 8 to 10 centimeters in size, with herniation of multiple abdominal organs, as we can see in the picture, into the thorax. This often leads with lung compression, mediastinal shift, and dense adhesions. So, traumatic diaphragmatic hernia, it occurs as a result of disrupted musculotendinous diaphragm following a blunt, more than penetrating thoracoabdominal trauma, which causes a sudden rise in transdiaphragmatic pressure. So when you sneeze, the transdiaphragmatic pressure is up to 25 millimeters of mercury. When you cough, it reaches up to 50. And when you vomit, it reaches up to 75 millimeters of mercury. In a blunt trauma abdomen, if the pressure crosses 75 millimeters of mercury and can reach up to 300, that is when the diaphragm gives up and ruptures. So there is very little incidence, which is 0.8 to 5%, although it is still underreported because most of the cases go missed. It is more common on the left side than on the right side. Why? Because on the right side, there is protective effect of the liver, there is congenital weakness of the left posterolateral diaphragm, and there is easier radiological detection on the left side because the right-sided injuries, they are often masked by a liver shadow. There is delayed presentation over weeks to decades, as late as 10 to 20 years have been reported in literature. So what is the mechanism of injury? We can see that is the diagram that have we seen in Gray's Anatomy in our first year of MBBS. It shows that the diaphragm is fixed on all sides, anteriorly on the sternums, on the sides to the ribs, and posteriorly it is attached to the lumbar vertebra. So the initial injury is due to sudden increase in intra-abdominal pressure against the fixed diaphragm. But why are the injuries missed initially? Because the small tears without immediate herniation, when the patient presents with polytrauma, the main focus is on the life-threatening injuries. And because the patient is intubated initially and there is positive pressure ventilation, which may temporarily reduce herniation, and there is poor sensitivity of initial chest X-rays. The diagram lower shows the types of tears that can happen. More common are the combined tears on the posterolateral side of the diaphragm. So what is the mechanism for delayed herniation into the thorax? So consider or imagine that the abdomen is pushing its organs upwards while the thorax is pulling them upwards. So there is a persistent pressure gradient with positive abdominal versus negative thoracic pressure. There is progressive enlargement of the defect, which leads to gradual migration of viscera into the thorax. So there is formation of dense adhesions when this viscera reach into the thorax with pleura, lung, and pericardium, and it stays there. So this progression is why the delayed cases, they're often large or giant, they're adherent, and they're surgically challenging. So this is the Grimes classification, which was given as early as in 1974 and is used till now. So there are 3 phases of a traumatic diaphragmatic hernia, which results into a giant one. So the phase 1 is acute phase, which occurs immediately after the trauma. They're often asymptomatic or they're masked by other injuries that patients present with. Second phase is the latent phase, which has intermittent or vague symptoms. Herniation is reducible here mostly, and patient may present with non-specific chest or abdominal complaints. I like to think a patient presented to us in the latent phase because in phase 3, which is the obstructive phase, there are acute complications, including bowel obstruction, strangulation, volvulus, respiratory distress. while most delayed giant hernias, they present in phase 3. So the patient usually present with respiratory more than GI symptoms. There are usually complaints of progressive dyspnea or reduced exercise tolerance. There are complaints of recurrent chest infections, and there are decreased breath sounds on examination on the affected sites. In GI symptoms, there are vague epigastric or chest pain, vomiting, postprandial fullness, and there might be features of bowel obstruction or ischemia in late cases. So diagnostic evaluation, as discussed by my radiology colleague, we go with chest x-rays first, while the computed tomography remains as the gold standard. What are the principles of the surgical management on these cases? You get diagnosed with a traumatic diaphragmatic hernia, you have to get it repaired because there will always be a risk of strangulation, there will always be a risk of progressive pulmonary compromise, and there might be a sudden deterioration someday. So the surgical objectives are very clear. You have to make a safe adhesiolysis. Then there has to be reduction of the herniated viscera. You have to assess the bowel viability, and a durable closure of diaphragmatic defect has to be made, or as here it was done, a formation of neodiaphragm has to be done. Then we have to restore the thoracoabdominal anatomy. There is no single superior approach for the diaphragmatic hernias that we have. An individualized decision has to be made from patient to patient. We can approach via thoracotomy or a laparotomy or a mix of both. It can be open or it can be minimally invasive. Thoracotomy is better for when we have dense thoracic adhesions and there is a difficult bowel assessment. Laparotomy helps when a bowel compromise is suspected. It can be approached by minimally invasive, as we started with. It can be video assisted thoracoscopy combined with or separately via laparoscopy. This is best for the selected and stable patient because this benefits with less pain and shorter stay. Then comes the hybrid approach. So the approaching both via laparoscopy and thoracoscopy and or combined with lap and open approaches. These usually have better outcomes, smaller incisions, less pain, shorter operative times, shorter hospital stays, happier patients. So in repair techniques, we usually have a primary repair and we reinforce with the mesh. So primary repair, we have to use the non-absorbable sutures because diaphragm moves all the time, it never stops. It is feasible in small to moderate defects up to 4 to 5 centimeter in size with good tissue when it is present. It has to be reinforced with a mesh when the defects are larger, when there is a tension on the primary repair and we have chronic fibrotic edges. So an article published in 2025 calls the delayed traumatic diaphragmatic hernias as tomorrow's emergency because it is usually present in 5% of the thoracoabdominal trauma cases. It is missed in 66% of the cases during the initial investigation, and the mortality rates are as high as 21 to 31% in untreated or complicated cases. So the retrospective analysis that was in 2019 included 40 patients with 90% of the patients having history of trauma, with majority of the cases being on the left side of the diaphragm. Thoracotomy was done in most of the patients, while 2 patients underwent a combined approach of thoracoabdominal. 36 patients sufficed with primary repair. 4 patients underwent a mesh reinforcement. Over 16 months of follow-up, 1 patient had recurrence of giant diaphragmatic hernia. So this article in 2022 says the traumatic causes in 50% of the patients that presented to them. And it says that the minimally invasive repair is superior than the open repairs because when it is done in 64% of the patient in this article, the median length of the hospital stay is 1 to 3 days, which is very significantly less than open repairs, which is up to 3 to 27 days. So to the best of our knowledge, this represents the first case of delayed right giant diaphragmatic hernia, which was successfully managed with neodiaphragm formation, with no prior literature describing this approach in such scenario, because sometimes rare problems demand new anatomy. So I would now like to invite our faculty, Dr. Devendra sir, to conclude. Thank you.
Good afternoon, respected seniors and colleagues. To conclude, giant right-sided traumatic diaphragmatic hernia with entire atrophy of the diaphragm and right above liver inside the thoracic cavity along with abdominal viscera is extremely rare and not reported in the literature, as my colleague has told. And imaging like CT scan is vital for making diagnosis, and it also provides a roadmap for further surgical planning. And this case poses an extreme surgical challenge, as there was no diaphragmatic rim to anchor the mesh. And secondly, primary repair or repair with mesh reinforcement was not possible. As you can see, the defect was very large. In such cases, hybrid approach, that is thoraco-abdominal, suits the patient as it provides safe reduction of abdominal viscera inside the abdomen and durable repair of diaphragm using a composite mesh in a tension-free manner. Innovative fixation technique like fixation of mesh to the interior intercostal muscles using a non-observable suture with U-stitch configuration provided safe creation of diaphragm with a durable strength. And multidisciplinary perioperative management is critical for good patient outcomes and prevent the rare complications like abdominal compartment syndrome. With this, I conclude the session and would invite Professor Chulin Sumbar sir, after our mentor, to say a few words over this case. Please. Sir, there is no definite timelines after which period the patient will present to us. Mostly, right-sided diaphragmatic hernia are usually present late because the liver provides a temporary effect and bowel is not getting there. Timeline is not. It- Sir, if the patient present to us in patient of polytrauma should be examined by CT scan because in simple X-ray at the immediate trauma the small diaphragmatic gland will not be picked up. But on CT, sir, mostly these cases of delayed diaphragmatic hernia, initially they are very small, but with passage of time, the defect enlarges and gradually the contents go upward. So it is a good point that ultrasound should be done in initial for screening purposes. Yes. Any more questions, please? Ma'am, if the defect is small, then it is better to go from thoracic side. But in this case, there was no diaphragm practically. So even if we go from thoracic side, the liver was inside the thoracic cavity. So the pneumo will not help to push the liver inside. So we have initially decided to make a certain space by pulling the bowel down, and then we have placed the port in the thorax also and push the liver inside the abdominal cavity. But it was not coming. Then we have to make 6 to 7 centimeter incision and push the liver and created a new diaphragm.
But here we thought there's a large space, it will take minutes to bring down the contents, but towards the place there is a lot of additions, we could not do that. Then we use the thoracostomic approach to do the gesticular exercise, push the content downwards. Again, it didn't help. Of course, we did a gesticular exercise, but there was some dense addition with the major abdominal vessels. So that mandated refractor. So we thought we just pull down the listener. Yes.
My history of trauma was significant. There was a history of fall of wall over the child at when she was 5 years old. So past X-ray was not there. It can be congenital, ma'am. We also thought it is a case of congenital diaphragmatic hernia, but the history of trauma was there, so it is a differential. Yes. Yes, ma'am. Thank you.